This is Dr. Frankie Holmes, and I'm looking forward to seeing you. In the time before I see you, I'd like to share some information about breast cancer to make our time more productive and to perhaps allay some of your concerns before you see me. I have a series of small videos that you can go through, possibly in sequence, or if you have already done your homework and want to move ahead, you can move at your own pace. I have a saying, "Speak the ghost and he is gone." It seems to me that the more we know about something, the less frightening it is for us. And I hope that in our meeting, I can take a lot of the fear or scariness out of breast cancer, and together we can work through to solve this. Welcome. So the first question is, why is caring for a patient with breast cancer so complex? And if you'll recall a book in the past called It Takes a Village, that really succinctly sums up what it's like to take care of a breast cancer patient. In the olden days, the surgeon was the lone cowboy who made all of the decisions. But now we understand breast cancer is a very complex disease, and it's more like an orchestra where everyone has to play a role at a certain time. There is a conductor, but he is the leader of an entire group of people dedicated to one purpose. We have a diagnostic team, and we have terrific folks in breast imaging and in pathology. The therapy team, which is going to be the medical oncologist, the surgeon, the radiation oncologist. We have a very important rehabilitation and survivorship team. This is going to be physical and occupational medicine, plastic surgery, fertility, nutrition, and your primary care physician and subspecialists such as your endocrinologists that are so important to us. On the next slide, I show how all of us have to not only work for you, but we have to talk to each other and to everybody in the team. It really does take a village. On the next slide, I want to give you an example of this. There is a certain subset of breast cancer called HER2, and as we'll show in one of the updates on research at the end of this, the FDA has approved a brand new medicine called pertuzumab that is able to be used for patients whose tumor has spread, but in the case of patients who receive it before surgery, so we can see how effective it is, it can be given before breast surgery. But right now, it's not approved to be given after breast surgery. So it's very important, if a newly diagnosed patient has a HER2-positive breast cancer, that she visits with the medical oncologist before surgery so that we can give this very effective medication. There's a famous scene in the movie Apollo 13 that speaks to me on this issue, and that is when the team that had been training for 2 years to the point that they could read each other's mind had to be torn apart because one of the astronauts' children had measles and they weren't sure if he was exposed, and he couldn't come down with measles 2 weeks later when he was in the capsule, so they kept him back on Earth. And he said to the commander, "Look, we can read each other's minds. We've trained for 2 years together. You can't do this." But of course, as we know, that was what saved the crew, because he could read their minds even when they were on Earth. But I share that just so that you understand how important it is for each member of the team to be in communication with each other. And that's the team that will be taking care of you. We like all members of the team to visit with the patient before treatment. And that means seeing the surgeon, seeing the radiation oncologists, sometimes seeing the plastic surgeon, certainly if further childbearing is an issue, seeing the fertility specialists. And more we've come to learn it is very important to have the fitness level assessed before treatment. So we will also have our patients see the physical and occupational medicine group for what is called rehabilitation. So then the question comes up, Why isn't surgery all that is needed for early breast cancer? On the next slide, I'm going to tell you why this is more than meets the eye. We have two compartments of breast cancer that must be treated. I'm going to talk about types of what we call local treatment for the local compartment, and then I'm going to talk about micromets, which is part of the systemic compartment. And then I'm going to explain to you why a PET scan can't see everything. On the next slide, I'm going to tell you here about the two compartments of breast cancer. And I have to remember one visit that just broke my heart. It was a beautiful young woman who said to me, "Hey doc, I had a small cancer, but I decided I'm going to do everything, right? I've got 2 kids. I don't want to have to deal with this again. I had a double mastectomy, so that's it, right? I'm all done." But unfortunately, that wasn't the whole story for her, because she needed additional treatment because she had a high chance of having tumor spread to other areas. Treatment to the breast and to the lymph nodes in the armpit, we call the axilla, is called local treatment to the location of the tumor. And the goal of good local treatment is first to remove the tumor with a clear rim of normal tissue, to check out the lymph nodes in the armpit, and if the breast and lymph nodes that are involved have been removed, then no additional local therapy may be needed. If there is extra breast tissue left over, if a person has a lumpectomy, or if there's tumor in the lymph nodes, then we will need radiation. The second compartment is the systemic compartment. And we know that even before we detect the primary breast tumor, microscopic tumor cells, we call them micromets, they can escape through lymph channels, often to the lymph nodes, but they don't have to stop at the lymph nodes. They can go directly into the bloodstream by the blood vessels. And this is the systemic component. This is the part that the medical oncologist treats. Okay, on the next slide, we ask the question, if surgery or surgery and radiation are both good treatments to the location of the tumor, that is, local treatment, is one better? Well, the next slide shows that there are 2 types of local treatment, surgery and radiation. There's 2 types of surgery. One is lumpectomy, an evaluation of the lymph nodes in the armpit. As you can see in the picture on the top, a small area of breast tissue is removed, and the way I think about that is, if you think about a sunny side up egg, imagine that the yolk is the tumor, the white is the normal tissue around it. So we want to remove the tumor with a clear rim of normal tissue around it. And then you see that small incision in the armpit or axilla. We need to check out the lymph nodes. And that allows us to preserve the breast, but it will require radiation to the breast and sometimes to the armpit area if there are many lymph nodes. The second kind of surgery is a mastectomy. And in the second lower panel, you can see a horizontal incision where the breast has been removed, and sometimes a separate incision is made, as you see there in the armpit, or sometimes they do it all through the same incision. It has been shown that if the tumor is larger than 5 centimeters, that is 2 inches, or if there are lymph nodes that have tumor, then we also need radiation, even though we do have a mastectomy. Well, on the next slide, we answer the question, well, gee, it seems like mastectomy is a much more radical treatment. Should we be doing mastectomies instead of lumpectomies? Is it better for me in the long term? Will it be less of a chance of the cancer coming back? Will I live longer? Well, Dr. Bernie Fisher was the visionary doctor who initially was involved in colon cancer. And he started studying the blood of colon cancer patients before he did colon surgery, and he found circulating tumor cells. So then when he became involved in breast cancer, he thought, we're doing these radical mastectomies on these patients, and it's very deforming. But if they've already had these cells leaking out of the tumor before surgery, are we closing the barn door after the horse has gotten out, so to speak? And so he was the one who pioneered lumpectomy with radiation. And so here you see three graphs comparing doing the mastectomy with the square boxes, the lumpectomy with the triangles, and the lumpectomy and irradiation with the black triangles. And in the first graph, we're seeing how long do patients live without the tumor coming back? And in the second panel, how long do they live without tumor coming back other parts of the body? And finally, how long do patients live overall with or without cancer? And in every single case, you can see that the lines are right on top of each other. So in the yellow box with the black writing, it shows that after 20 years, there was absolutely no difference. This study did not include patients who had any known BRCA mutations, and that's a small fraction of breast cancer patients anyway. So overall, we can say all of these treatments, mastectomy, or both of these treatments rather, mastectomy or lumpectomy and irradiation, are equally effective at preventing patients from having breast cancer come back in other parts of the body and from allowing them to live normally. Okay, in the next slide, we're going to talk about that other compartment, the systemic compartment, the micrometastatic compartment, micrometastases, micro meaning microscopic, and metastasis meaning spread. So one of the questions that I hear from patients that explains how difficult it is to grasp this concept is, but I had a PET scan before surgery. Why didn't the PET scan show tumor spread? And this relates to size and the limits of our technology. So look at the fingernail on your ring finger. And for most of us, if you just cut that off right at where the cuticle is, you have a sphere that's about 1 cubic centimeter. And in that are 1 billion cells. That's hard to figure out what a billion is. But if you look at the graph on the right-hand side, in 1982, the population of China was estimated to be 1 billion. It's continued to go up there. But that puts it a little bit in perspective. So now imagine grind up that 1 cubic centimeter and spread it all throughout the body. We don't have any technology that can visualize microscopic tumor cells that have spread. We can't see 10,000 cells in the lung, or 20,000 in the thigh bone, or 50,000 in the liver. So what we have to do is to use prognostic factors, or characteristics of the tumor, to help us predict who has a chance of micrometastatic spread. The next question comes up about different types of breast cancer. A favorite expression we have in caring for patients with breast cancer to explain this is the concept of the queen size pantyhose. One size fits all. We used to think of breast cancer that way until science helped us understand that there are many different types of breast cancer. And if you flip the next slide, you will see that the little Russian doll has many tiny little Russian dolls inside of her. And that's a good analogy of what breast cancer is like. Breast cancer has many different subtypes that are defined by what I will talk to you about, prognostic factors. And it is these prognostic factors that help us determine treatment. We also look at stage, and we'll talk about what that is, and then an increasingly complex area where we marry subtype and stage to come up with the best recommendation for you. So what are prognostic factors on the next slide? Prognostic factors are molecular characteristics that have been found to predict the aggressiveness of the tumor. And there's 3 main markers. The first 2 are hormone receptors, ER or estrogen receptor, and PR or progesterone receptor. The normal for these in a normal breast cell is positive. A third marker was discovered by Dr. Dennis Slayman, another visionary doctor, called HER2, and the technical name is HER2/neu, The normal for this in a breast cell is negative. There are two other supportive markers. One is called grade, and grade is how does the cancer cell look under a microscope? Does it look very different than a normal breast cancer, or does it look very much the same? One of the analogies I use to help explain grade and how it relates to the aggressiveness of the tumor is grade 1 is Gomer Pyle, grade 2 is G.I. Joe, and grade 3 is the late Osama. So that helps us understand the way the tumor looks can give us a clue to how it might behave. A second supportive marker that goes along with grade is called the proliferative rate or growth rate. This is often reported as a Ki67 or an MIB1. Fast-growing tumors are more aggressive, and they also respond more to chemotherapy. Slower-growing tumors are less aggressive, and they don't respond as much to chemotherapy. Often they respond to hormone therapy. So now if we put all of these markers together, it turns out there are 4 main subtypes of breast cancer. And the next slide shows us a breakdown of if you had 100 patients with breast cancer, what are the relative percentages of each of these? So most breast cancer arises from tumors that are from breast cells that are hormone receptor positive, and so you can see here about 65% of patients in the light blue are hormone receptor positive, ER positive. The PR can be positive or negative, and the HER2 is normal. The next component is what we call the triple positive, and this is about 12% of patients, and it's in the dark blue. These are ER positive, PR positive, and HER2 positive. The third type of breast cancer are the HER2 positive breast cancers that are hormone receptor negative. So these are a very aggressive type of cancer. But as we'll see in a minute, these very aggressive cancers are often the ones that respond the best to treatment. Finally, you may have heard about something called triple negative. These are tumors that do not have estrogen or progesterone receptor, and they also don't have HER2 receptor present. This group is very interesting to us because these cells are somewhat foreign to the breast, but the things that are so exciting to us about this group of tumors is, first off, there are many different types of them. Secondly, these are the types that may be the most sensitive to immune suppression. And finally, we're figuring out how to get the immune system activated in breast cancer, because when your immune system recognizes something as foreign, there is no place that cell can hide in your body. So this is going to be something very important in the future. The next area that we're going to explore is how does the subtype determine treatment? On the next slide, we will explain that knowing the subtype tells us about the vulnerability of the tumor, and that's how we can decide on the treatment. So the prognostic markers tell us which pathways does that tumor use to grow. And these are the pathways that we will target. For example, if a tumor is hormone receptor positive, that is ER and PR positive, or ER positive but PR negative, these tumors need estrogen. And there are various pathways that get activated when these tumors grow. So an obvious strategy is to block the estrogen pathway. And one of the things that science has revealed to us, the results of clinical trials, is that, what a surprise, cancers have backup pathways, like whack-a-mole. So much of the new effort at curing ER-positive breast cancer is now also targeting these backup pathways. And I'll tell you about that in the research part. The second is the HER2 pathway. In this group of tumors, when HER2 is activated, then we block HER2. And this is an exciting part of immune treatment because the blockade for HER2 is pretty much antibodies, getting the immune system engaged. Finally, these very aggressive triple-negative breast cancers, these are the ones that have very high growth rates, high proliferative rates, which we measure by the Ki-67. And these are the ones that are more sensitive to chemotherapy. So the next question we will address is stage. What is stage? Cancer stage tells us how big the tumor is and if it has spread to lymph nodes or other places. Before we understood all that we now know about the pathways and the molecular biology of tumors, we only had anatomy. And anatomy tells us how big is the tumor. That's what we call the T stage. Has it spread to lymph nodes? We call that the N stage. And has it spread outside of the breast? That is the M stage. So we use the size T and the spread N and M to group breast cancer into different stages with the idea that it would predict the outcome. There is a group called the American Joint Commission on Cancer, or AJCC, that defines these groupings. And every so often, based on new data, they revise the groupings. The present version is called version 7. And on the next slide, you see a representation of how we divide up the T, the tumor size, the N, the lymph nodes, and the M. Tumors that are less than 2 millimeters, less than or equal to 2 millimeters, are called T1. Tumors that are greater than centimeters, so they have it listed here as millimeters. 10 millimeters is 1 centimeter. So 10 to 20 millimeters is 1 to 2 centimeters. A T2 is greater than 2 centimeters to 5 centimeters, and 5 centimeters is just about 2 inches. A T3 is over 2 inches or over 5 centimeters. And a T4 is when the tumor either grows back into the chest wall or involves the skin. There are various what we call lymph node stations near the side of the breast, high up underneath the pectoralis muscle, and then beneath the collarbone, above the collarbone. These are various lymph node stations, and depending on where the tumor has spread to, that tells us how aggressive the tumor is. Finally, distant metastases means has the tumor spread outside the area of the breast and lymph nodes, and that's the M status. So on the next slide, we see how we integrate the T, the N, and the M into a stage. And in the days before we understood breast cancer so well, we had correlated the stage with the survival rates. And you see the graph on the right side shows that it's very tippity top. Tumors that are small, that don't involve the lymph nodes and don't go outside of the breast area in this peacock blue color, they seem to do very well, you can see at 5 years. Whereas tumors on the very bottom in the brown colored line that are labeled M1, they don't seem to do so well at 5 years. This, however, does not incorporate all of the information that we have learned since the very beginning of biology about the hormone receptors, the HER2 receptors, etc. So this is the part of breast cancer that is now bumping up against the new findings. So the next question is knowing the stage enough to determine treatment? Well, I've kind of alluded to that before, that in the olden days, all we had was how big and how far to guide us in treatment. But now we have biology, we have behavior. So my son was a big transformer person when he was a little tyke, and so I'm putting on one of those transformer heroes who are all loaded up with weapons. And I'm also putting on a micrograph of an Ebola virus. And so, assuming that transformer person could be real, who would you think is more dangerous? Is it the size or is it the biology? So this is an area on the next slide where we are integrating both the anatomy and the biology. And sometimes these don't agree because we can have a very big tumor that is very slow growing and doesn't have aggressive characteristics. So even though it might be a T3, it might not be as aggressive as a very fast-growing T1, tiny tumor. So one thing that can help us is doing molecular testing on the tumor. And that provides us with personal information about what makes that tumor grow and divide and want to spread. And we compare that to the anatomic stage statistics. One of the most common ones, and the one that I use a lot, is called the 21 gene assay, or Oncotype. And what is really exciting about this test is that it was done by analyzing the molecular results of patients' tumors treated almost 20 years ago in patients who either had the appropriate local therapy followed by an anti-hormone, or the appropriate local therapy followed by chemotherapy followed by an anti-hormone. So we have a very important set of data that tells us, gee, do we need chemo in this tumor, or maybe we could just use anti-hormone therapy alone? There are other types of tests. One is called MammaPrint that also is stratifying in terms of risk, but it did not have that crucial comparison of this patient got chemo, then hormones, this patient got hormones. Can we tell if that chemo added? So I don't use MammaPrint very much. And then finally, just to give you an example of how this biology is so important, there is a kind of breast cancer that's not very common called invasive lobular. And it comes from the glands that make the milk. And this is only about 10% of breast cancers. Most breast cancers come from the ducts that transport the milk. Invasive lobular is usually a very slow-growing tumor, not very sensitive to chemotherapy, regardless of how big it is and regardless of how many lymph nodes it goes to. So invasive lobular cancer is one that anatomy and biology don't always agree upon. So on the next group of slides, we'll ask, how do we put all of this together to decide on the best treatment? Well, there are 4 factors that help us figure out what is the best systemic treatment. First, we say, what is the goal of treatment? For early stage breast cancer, that is stages 1, 2, or 3, cure is the goal. For stage 4, or advanced breast cancer, control is the goal, management. We use prognostic factors, the hormone sensitivity, the HER2 status, and supportive markers. The third component is determining the risk of recurrence, and that's how the Oncotype, the 21 gene assay, can sometimes give us very important information about the benefit of chemotherapy. And then finally, we have to see what the patient wants and what her overall situation is. We can't make recommendations without considering all 4 of these items, and most importantly, what does the patient want to do? One of the programs that we often used to help us statistically is a program called Adjuvant Online, developed by Dr. Peter Ravden at UT San Antonio. He's a very, very smart breast cancer doctor, and in a very complimentary way, I want to say he is a math nerd. He summarized all of the reported clinical trials, and he was able to give a consensus about the T size, the N size, the grade, and the estrogen receptor status, and his program has a very easy to understand set of graphs. But all of this was done before we had a lot of the molecular information, so we don't use it as much. It did not include HER2. It is very useful from a historical standpoint. Importantly, we have to make a distinction between statistics, which talks about a population, that is, if we had 100 women with this situation, how they would do, versus specifics, which is what the molecular tests do. They look at the tumor genes in a specific person. On the next slide, we talk about the test that I often use, the 21 gene assay called Oncotype. It is only useful for patients who have hormone-positive breast cancer because the question is, can we give anti-hormone therapy only, or do we also need to give chemotherapy? And so as you can see on the graph, I put the colors in just like a stoplight. The recurrence score, which is on the horizontal line at the bottom, going from 0 to 50, in a rough way, is like the number of mutations the tumor has. The vertical line on the left-hand side says what is the 10-year risk of the tumor coming back in percents. So I have divided with blue vertical lines the three groups. One group that's below 10 is a low risk for the tumor coming back. The group from 10 to 25 is an intermediate group, and the group from 26 to 50 is a high-risk group, and thus green, yellow, and red. There are two lines that go across the graph. One is a dotted line, and that shows the patients who took tamoxifen and chemotherapy. So they took chemotherapy, then they took the anti-hormone. The black solid line shows the patients who only took the anti-hormone. In that first group that has the green arrow, there's no difference between the black solid line, taking the anti-hormone pill only, and the dotted line where patients also took chemo. In the third section, where the red arrow is, there's a big difference between just taking the pill, which shows the risks of cancer returning in 10 years to be going on up there to 35%, versus the dotted line where patients also took chemotherapy. So this is the kind of information that helps me make a recommendation. Gee, should we take chemo in addition to anti-hormone for a hormone-positive tumor that does not go to the lymph nodes? Or, hey, if it's a low enough risk, maybe less than 18 or 16, maybe we can get away with just anti-hormones, especially because we have many more effective hormones than tamoxifen alone. In this next section, I'm going to answer a question that may have already come up in the back of your mind. What is the difference between molecular testing of the genes in the tumor and genetic testing for breast cancer, like what Anjali Jolie had? So here's a point of differentiation. When a tumor develops, it is because the cells in the tumor developed mutations, and these we call somatic mutations. The way to think about this is, let's say a soldier has his leg injured in Afghanistan and has to have it cut off, and he comes home and he and his wife have a baby. Will the baby have a leg? Well, sure, because there was no injury to the genes inside of his sperm that had all the instructions for a completely normal human being. So that did not affect his germ line. The germ line are the genes that we inherit for parents. They're present in every single cell, and they can be passed to children. Fathers pass it to sons and daughters, and mothers pass it to sons and daughters. The BRCA mutation that Anjali Jolie had, those are germline mutations, and they were passed, in Anjali Jolie's case, her grandmother to her mother, and then unfortunately to Anjali Jolie. This type of mutation can cause hereditary cancers of the breast and ovary, and some other kinds of cancers, but at a much lower frequency. Fortunately, only about 10% of breast cancers are this hereditary type. We do test for BRCA mutations, but only if there's a reasonable probability of a mutation. And I've listed some of the reasons that make us suspect a mutation. That is, if a breast cancer happens at a young age, under 45. Breast cancer is a disease of older women generally. So if it happens at a young age, There must be something different making it show up. Triple negative breast cancer has been shown to have a higher incidence of BRCA mutations, and so we test those patients if they're under 60. If there's a strong family history, that is, breast cancer is under age 50, but there's at least one first or second degree family member that has breast or ovarian cancer. A first degree family member is a first level, so that would be your mother, your sister, or your child. Or if you have breast cancer at any age, and there are two family members on the same side with breast cancer or ovary cancer. There are a number of other items that we can go through and will go through at the time of your visit. And so that's why it's so important to me that you fill out the family history part of the form, the new patient information sheet. And I'm going to thank you in advance, because sometimes that means calling family members to find out, what did Aunt Marie pass from and how old was she? Finally, there are groups of patients, and I have that on my form when I ask if you have any Ashkenazi Jewish heritage, any Dutch heritage, any Icelandic heritage, because there are groups of patients that just have higher chances of having that mutation. It's important to know, for obvious reasons, if you have a mutation, because it could affect your decision about the type of breast surgery that you have, that is a lumpectomy or a mastectomy, and also about what we should do about the ovaries possibly. The next slide is one of my favorite pictures. It was the op-ed piece that Anjali Jolie wrote when she shared her discovery of the BRCA1 mutation with the world when this was published in the New York Times on May 14th, 2013. And if you look at that cartoon picture, it has a very powerful message. What do we see in that picture? We see the children holding on to their mother. And what don't we see? We don't see the breasts. She says it all in that one powerful picture. It is my children that I am doing this for, my grandchildren. These are what are important to me. And these are the kinds of decisions that we have to make when we discuss this. Okay, in the next section, we're going to talk about the sequencing of treatment for early stage breast cancer. Is there a preferred sequence of surgery versus chemotherapy? On the next slide, we talk about the usual sequences. For tumors that are small and able to have surgery first, we give chemotherapy after surgery. So the sequence would be surgery, check the tumor to decide if we do need chemotherapy. That is, does it go to lymph nodes? Is it a fast-growing tumor? Is it have other important changes? Then we generally give radiation if it's needed, and then if it's hormone positive, we give anti-hormone therapy. However, for tumors that are too large for surgery, or are triple negative, or are HER2 positive, we would give chemotherapy first, and we call that preoperative chemotherapy or neoadjuvant chemotherapy. After chemotherapy, then we do surgery, then we do radiation, and if the tumor is HER2 positive, we would continue anti-HER2 therapy, and if it is hormone positive, we would start anti-hormone therapy. On the next slide, we answer the question, well, why the heck would you give chemotherapy first? Don't you want to get rid of the tumor? And there are two reasons. First is, if we give the chemo first, it can shrink the tumor, as you can see in the top panel, and that might mean that it's a lot easier to do surgery because we wouldn't have to take as much of the tumor, and maybe a patient could have a lumpectomy instead of a mastectomy. However, as you see in the middle panel of that first panel, sometimes tumors don't shrink like a snowman melting down into one puddle. Sometimes they shrink into little tumorlets, kind of like a pizza pie. And in that situation, even though the tumor shrinks, we still have to take the same amount of breast tissue out. The second reason, and shown in the second panel, is that if we use the tumor in the breast as an indicator of how the tumor that has spread, those micrometastases that we talked about, we see that it can be a predictor of how sensitive the tumor is to chemotherapy. And it's been shown that if all the tumor goes away, like the very last panel on top where there's no more tumor cells left, the patient has an 85% chance of the tumor not coming back. Unfortunately, in the red on the bottom panel, if the tumor doesn't go all away, or if it gets worse, then that tells us this tumor is not sensitive to that treatment, and we might need to think about a different kind of treatment later on. On this next section, I'm going to talk to you about something very near and dear to my heart, clinical trials and why they are so important. On the next slide is a picture of one of the articles in the New York Times that I thought was so useful to explain how every patient is a part of the search for the cure of cancer. And the heading is absolutely on target. The road to cancer treatment, and you can put possibly cure, is through clinical trials. And these are some of the sites that you can go to find out clinical trials that are applicable to your situation. I am actively involved in clinical trials research at my Memorial City office, and some of our trials are listed on the bottom website below. I will discuss clinical trials with you if your situation is one that is amenable to a clinical trial. Recently, on the next slide, Dr. Mukherjee, who wrote a book, The Emperor of All Maladies, which was made into a serial on public television, a 3-part serial by the same person who did the serials on the Roosevelts, the national parks, and the Civil War, Mr. Burns, commented about the role of clinical trials. In pediatrics, because care of children with cancer is such a very specialized, unfortunately not so common, the pediatricians long ago realized they had to all band together. The way in Houston, the Texas Children's Hospital actually has made satellite clinics of most of the pediatricians' offices here in Houston, so that there is strength in the numbers, that all of the doctors are talking to each other, and these rare tumors, when put together, can be studied in large enough numbers to make an important discovery. And so what he said here, the outcome of cancer clinical trials in children is so stunning because 80 to 90% of young patients participate in clinical trials. Every trial taught doctors something that led to further trials and better results. But only about 5% of adults with cancer enter a clinical trial, and that is not nearly enough to move cancer medicine forward. No matter what we do in the lab or in basic science, the ultimate proof of which medicines work comes from clinical trials with patients, and that's so important. So the next slide will highlight some of the changes in the way we treat breast cancer based on clinical trials that were published just within the last year, just since 2014. These are 3 treatments, and these are the investigators here: Dr. Prudence Francis, Dr. Sandra Swain, Dr. Dennis Slayman, and Dr. Richard Finn. The first trial that I will talk about is the trial that showed, unfortunately, that we have to become an estrogen desert. This is the SOFT and TEX trial. This is the one that tells us that breast cancer that arises in a premenopausal young woman arises in an environment where the estrogen levels are very high, and that in order to have the most significant impact on that tumor, we have to change that environment to an estrogen desert. And that means, unfortunately, suppressing the ovaries. So this trial was called the SOFT trial, the Suppression of Ovarian Function trial. And this was for premenopausal women who are estrogen receptor and or progesterone receptor positive. This was an international trial across the United States, Europe, and Australia. One of the important commentators on this was Dr. Hope Rugo, and she's from the University of California, San Francisco. Basically, this trial joined with another trial called the TEXT trial to answer the following question. If a young woman has breast cancer, can we just give tamoxifen, which is an estrogen-blocking pill, or do we need to give tamoxifen and block the ovaries? Or do we need to give a medicine that works only if the ovaries are blocked, exemestane, which is an aromatase inhibitor and which has been tested in postmenopausal women and shown to be more powerful than tamoxifen? Do we give that medicine and block the ovaries? And is one of these more effective at preventing the cancer from coming back and helping patients live? This was an analysis of almost 5,000 patients, and they had to follow these patients for over 5 years. The next slide shows the results in a graph form. Now, I know a lot of us aren't people who do graphs all the time. So the key thing is up at the very tip top on both sides is the 100% mark, and I put a dotted pink line. On the very bottom, the horizontal line is years since the patients got started into treatment. So what we want to do is we want to figure a treatment that is going to get us as close as possible to that dotted pink line up there. And the treatments that were given are color-coded. So tamoxifen, which is the greenish-blackish line, that's the standard. That had been the standard up until now. And you can see with the bright pink arrow, it's pretty far down from the dotted pink line. But the blue graph line, which is the exemestane plus the blocking of ovarian function, is much closer. And you can see there that it was 35% better to block the ovaries and to give the other medicine. And on the graph on the other side, we are looking at what is the percent of women who remain without any disease. And you can see the same trend. It is blocking the ovaries and giving the medicine that further lowers estrogen. An important part of this study, on the next slide, is that it looked at women who had breast cancer under age 35. So these are women whose estrogen levels are very, very high. And what you can see there, again, with the big pink line arrow and the smaller yellow arrow, is that taking the pill alone, the black part of the graph, was much less effective than blocking the ovaries and giving the medicine that further lowered estrogen. In fact, if you took tamoxifen pill alone, 1 in 3 women had their tumor come back. But if you took the suppression of the ovaries and the blockade of estrogen formation pill, only 1 in 6, so 50% fewer patients had their tumors come back. So the new recommendation on the next slide that Dr. Rugo shared with us at the San Antonio breast cancer meetings is, if you have a low-risk small tumor, it doesn't involve the lymph nodes, and it's slow growing, it's a Gomer pile, okay, you can just take that tamoxifen. We think that 5 years may not be enough. It might need to be 10 years, but you don't need chemo, and you probably don't need to have your ovaries turned off. If you have a high-risk tumor on the right-hand side, then you probably are taking chemo, and if the chemotherapy doesn't make your ovaries go into menopause, then you need to take the shot that stops the ovaries from making estrogen and take the pill, exemestane, that stops the body from making estrogen in the fat cells and inside any tumor cells. And then there's that group of patients in the middle who maybe need chemo, maybe don't, but do need to have more aggressive blockade of estrogen. These are things that we would talk about at the time of our visit. The next slide shows the obvious downside to this, and that is early menopause. On the top left is an app that's free on iPhones, and they're trying to make it, I think, for Androids. It's by the North American Menopause Society, and it's called Meno Pro, and it has lots of good information about how to deal with these side effects. Also, at menopause.org, which is the website for the North American Menopause Society, are many information sheets that can help to deal with this. These symptoms can be very bothersome. They can last a long time, but there are ways that we can minimize them. Exercise, maintaining optimal weight, changing our diet, getting enough rest. There are all ways that we can help manage that, and we'll discuss these with you. The next trial is the Cleopatra trial, and this was another very exciting trial that incorporated the results of science. It showed that double blockade of HER2 is more important than only single blockade. On the next slide, it seems pretty complex, but Dr. Sandra Swain was the one who presented this information. We told you that breast cancer has HER2 cells, HER2 molecules present on the surface, and they are shown underneath Dr. Swain's picture in the blue, the HER2. But actually, HER2 has some other partners, HER1, HER3, and HER4. And in the middle panel there, it shows that HER2 and HER3 bind together. So the blue molecule and the green molecule bind together. And this is a very powerful signal to the cell to tell it to grow and divide. And if we look in the big panel at the bottom on the left-hand side, we can see that when HER2 and HER3 bind together, it sets up a huge domino effect in the cell that causes these signals to go from the outside of the cell, the blue membrane, down through, again using the analogy of the sunny side up egg, where the white would be the cytoplasm, into the yolk where the genes live, and that's shown here demarcated by the purple double line. This domino effect goes through the white into the yolk to tell the cell to grow and divide. That's the proliferation part. It also tells it on the left-hand side angiogenesis, to make blood vessels to support this growth. So this is a very powerful grow and divide signature. So the Cleopatra trial compared taking chemotherapy with trastuzumab, we also call it Herceptin, that's the trade name, to the combination of pertuzumab, which blocked HER3 as well. So now you're blocking HER3 and HER2 instead of just HER2. And in the graph below, it was shown that if you had the combination, which is in the red, compared to the single anti-HER2 in the blue, that all the patients were living longer. In fact, they lived 32% longer. That is, almost 1 in 3 were living, and it was almost for 5 years as compared to about 3.5 years. So this was a huge win for us and has now become the standard of care for stage 4 breast cancer and, as I mentioned earlier, for HER2 positive early breast cancer if we can treat it before surgery. There is one other really exciting trial that has led to the FDA approving a new treatment just this March 2015. And that's on the next slide, the Paloma trial. this discovered a completely new class of medicines that helps anti-hormone treatments work better. On the next slide, you see an ignition switch. Every cell, when it starts to go through growth and division, just like an engine, it has a startup. And that startup is the cyclins. This group of new drugs are inhibitors to the startup. The way I think about it is like those patients who've been convicted of driving under the influence that have to blow into a little pipe before their engine can start. And if there's alcohol, it will not allow the ignition and the engine to get going. This medicine is exactly like that. It prevents the cell from turning on its cell cycle to get the cell getting ready to grow and divide. So it doesn't matter if HER2 is sending a signal or estrogen is sending a signal. This is blocking the engine. And these are the cyclin inhibitors. So Dr. Dennis Slayman, who initially discovered the HER2 molecule, has a protege in his lab, Dr. Richard Finn, and they were the ones that helped develop this drug, which is a CDK or a cyclin inhibitor. And you see how it works in the panel down at the bottom. And on the panel at the right, you can see the results of the clinical trial where patients agreed to be a part of, comparing taking letrozole, which is a standard estrogen blocking treatment in the brown, to the letrozole plus this new medicine called palbociclib in the blue. And you can see that the chances of the patients living without their tumors growing was very significant. We generally look at what we call the median. That is, if you go to the 50% mark on the vertical line and you run your finger across, you can see the difference is that with letrozole alone, it was able to control the tumor for 10 months. But if you took the double treatment, it was able to control the tumor for 20 months, almost 2 years. Some other recent discoveries have told us that we don't only need expensive medicines, but there are things that we can do just with our daily life to help us beat cancer. And the next slides will show us what they are. There are 3 different researchers who have just published information about this. The first is about the effect of obesity and not being active. The second is the effect of obesity on the effectiveness of our medicines. And then finally, the last is about our fitness level. So this first study was published by Dr. Ewerts, and she looked at almost 20,000 Danish breast cancer patients who were treated between 1977 and 1996 and followed at least 10 years to see if their cancer had gone back and at least 30 years to see if they died. One of the great things about those Scandinavian countries is that because they have socialized medicine and everyone has a unique number, boy, they know when you're born and when you die and what happens in between. And in the big graph here on the left-hand side, she shows the chances of the tumor coming back in black based on the body mass index, the chances of the tumor coming back in the thick lines based on your body mass index. Your body mass index is a mathematical calculation of your height and your weight. 19 to 24 is normal. 25 to 30 is overweight. Over 30 is considered obese, and over 40 is considered morbidly obese. And the key thing is that in this trial, you see the brown curve, it shows that the highest chance of the tumor coming back were in the people who were heavier. And similarly, in the tiny graph in the bottom right, it shows that the highest chance of dying from breast cancer were in those patients who were heavier. So this is something we can do something about. This is a reversible or correctable problem. And there's a lot of research going on to why this happens. And on the next slide, we see what some of these are. It is thought that when a patient is heavier, there is a change in the amount of insulin that's produced. We know that there is much more inflammation in patients who have more adipose or fatty tissue. There's a change in the levels of the sex steroids because fat tissue can convert male hormones into female hormones, and that can help stimulate breast cancer. And also lipids have different effects on the tumor. And in the picture of the tumor cell there on the right, we can see that these changed levels of these chemicals in our body can help the tumor grow. Angiogenic factors are factors that help the tumor make blood vessels. So all of these things are favorable for the tumor to survive and come back faster. This next slide is an important study by Dr. Nat. He's one of our colleagues in Austria, and he looked at the effect of being normal weight or being overweight or obese on how powerful one of our best medicines is. And in the graph on the bottom on the left, he looked at the normal weight patients, and on the graph on the right, he looked at the patients who were overweight and obese. And on the next slide, we see a composite graph. So there's two different graphs here. On the top are the normal body mass index patients, showing what we learned from the original studies, that the medicine that I labeled as ANA, which is anastrozole, that stops estrogen from being produced in the body of a postmenopausal woman, compared to not taking estrogen, that they did much better in terms of living without their cancer coming back and living overall. But when he looked at the patients who were overweight and had a high body mass index, there was no difference in those curves. So that the chemicals that were produced by the fat cells could negate the effect of the anastrozole, which decreases estrogen levels. So this again is something that we can do something about. In this next slide, we learned something really amazing about the state of our health even before we have any treatment for our breast cancer patients. And then what is the effect of the treatment on the state of the fitness level? And again, this is something we can do something about. So this is something that's under our control. The next slide shows Dr. Kathy Miller. She is a professor at Indiana University, and she got interested because of the fatigue question that patients complain to her about, being so tired. And part of being tired is often being deconditioned. So she wanted to figure out, gosh, how fit are patients before treatment, and how does the treatment affect them, and how quickly can we get them back to their best level of fitness? So what she did is she looked at 23 patients who were taking chemotherapy, and then some of them got anti-hormones, some of them got anti-hormones only, and some of them had just surgery and radiation. And the way we evaluate fitness is to check and see how much oxygen your body has to use to do a certain amount of work. So she had patients on a stationary bicycle, and they measured that oxygen consumption. The second thing they did was they did a scan to measure the total amount of body fat and lean muscle. On this next slide, we see the results of her study. There are two graphs, and on each graph there is a green line, and that is the normal level that we would expect for a patient who didn't have breast cancer. She also has bars showing the different types of treatment. The pink bars are those from patients who had chemotherapy and then may or may not have had hormones, and the blue bars are those patients who had no chemo, only hormone therapy. And the first thing that you can see on the peak power is that whether you got chemotherapy or hormone therapy, you were way below a normal person. So most breast cancer patients are not very fit when they start out. In the second group, which says 6 months, it shows that most of the patients weren't better by 6 months. And then even at 12 months, they weren't much better either. So this tells us that most patients are really not in the best conditioning before they start treatment, and treatment causes patients not to get in better shape either, so that by the time you finish your treatment, you're really not in condition to start with the usual recommendations for exercises and activity that we often prescribe. And on the next slide is what I want to do about it. I want to send every one of my patients to what is called prehabilitation before any treatment at all. This will allow the physical medicine, the occupational medicine doctors to, number one, evaluate your shoulder to determine the range of motion, and secondly, to evaluate your overall level of fitness. On the next slide, I'm going to show you a study that answers a concern that patients and doctors have about what care must be taken on the mastectomy or lumpectomy arm. That is, can we have blood pressure? Can we have blood tests done? Will that increase my chances of getting swelling of the arm that we don't want, that is, lymphedema? The next slide, it's pretty complex, but it shows a study that was done at Massachusetts General Hospital in Boston. So this is one of the lead thought centers for medicine and cancer medicine. And the picture right beneath that shows a special kind of a test called pyrometry, in which a person's arm is put in, and at each point along that frame that moves back from the armpit down to the finger, it measures the circumference of the arm very precisely. And so they did this study in 710 patients. About 560 had surgery only on one side, and 160 had surgery on both sides. And it was about 50-50 lumpectomy versus mastectomy. And most of the patients had the lesser form of lymph node surgery called a sentinel lymph node biopsy. Only about 1 in 5 had all of the lymph nodes removed. And what they found from this was taking blood pressure, doing blood tests, none of that made a big difference. Not even taking airplane flights, because we often counsel patients to get a compression sleeve for when they take airplane flights. The only thing that was associated with increasing lymphedema was if you had injury or infection. So that's very reassuring to us. In this next slide, I'm going to summarize some of the areas that are being studied in clinical trials and also let you know how you can find out about them. This is one of my favorite pictures here from the lab of Mary Dissis in Seattle, Washington, and it shows a cancer cell with a lymphocyte, one of our own immune system, attacking it. And in fact, you can see another lymphocyte in the back at the 2 o'clock position attacking the tumor cell. This is an exciting new area for breast cancer research, is getting the immune system to recognize the cancer. As we talked about earlier, there is a lot of research going into lifestyle changes. That is, getting us into better physical shape, getting the levels of obesity lower, changing our diet. For patients who have the triple negative breast cancer, there is so much research going on, asking questions about types of chemotherapy, the platinums, whether we need to give medicines against the BRCA type changes. As we mentioned earlier, the new medicines that inhibit the cyclins the ignition switch of the breast cancer cells. These are only approved in spread or metastatic breast cancer, but obviously the next step is to study these in earlier breast cancer. And importantly, as we talked about, when we give chemotherapy first to a cancer and the cancer doesn't completely shrink away, we want to know what are the changes inside that tumor that make them resistant to treatment. As Dr. Mukherjee said on television, in the book, and in the slide that I showed, it's only by getting patients to be a part of clinical trials that we can improve the care of our patients. If you are interested in clinical trials, and if we have any clinical trials, we will review them with you. And I look forward to talking to you about this very important part of your situation. You don't deserve breast cancer, unlike patients who get lung cancer, often who smoked, or some of the other kinds of cancers that there are lifestyle causes for it. Nobody deserves this, but one of the things that oncologists always like to do is to make lemonade out of lemons, and perhaps the unfortunate situation of you getting this breast cancer can be a double win for you with a good treatment, and perhaps for people that you love who may get breast cancer in the future. Thank you.